Hi guys, Dr. Annie Heaps. We're going to go ahead and get started here. Let me just make sure I am okay. You guys can all see my screen. That looks right. Okay, sorry. I'm trying to go live on all the different platforms and it just always takes me just a second and it never wants to immediately work for me. But I think we are all good now and we are good to go ahead and get started. We have a lot of content to cover with thyroids today, so we will go ahead and jump right in. If anyone has any questions, you can go ahead and put them down in the chat. We have people joining from kind of all over the grid today because I've got you guys on Zoom. I have you guys on Instagram, on YouTube, on TikTok. So drop them in the chats. I won't be able to see everything. If you're in Zoom, I should be able to see that pretty easily. And if I don't get to your question, just leave a comment on our Instagram or on our TikTok. I will make sure that I get back to you, whether it's email or in a DM or whatever. So without further ado, guys, welcome. Like I said, my name's Dr. Annie Heaps. Annalise is my legal name, but everyone just kind of calls me Annie. I am thrilled to be giving this webinar today. This is a new one for us, thyroid disorders, because this topic is incredibly close to me. You will treat a ton of thyroid disorders. I think about 1 in 4 women in the United States over the age of 35 has a thyroid disorder. So this is something that you are going to see all the time. It is underdiagnosed a lot of time. A lot of women live with these symptoms and never get a diagnosis, never get on proper medication. I live with it myself. Hashimoto's is very prominent in my family. I was diagnosed with it a few years ago, back when I think I was about 22 when I was diagnosed. That experience really shaped how I approach patient care, how I approach patient education, how I look at everything. And so because of that, it's really important to me that we have these conversations. So, as we look at all of these things, let me jump in here. Give me just 1 second. Let's see. I just want to make sure everyone who's live on the other platforms can see and hear everything okay, so I am not muted. Okay, sound should be good. Until I see something saying otherwise in the chat, I'm just going to assume that on Zoom and YouTube, you guys can all hear me okay. Okay, moving on to some disclosures. We have to start with these, just a few quick things to go over. This course is accredited for 1 contact hour, but you do need to attend at least 80% to receive credit. And that 80% is determined by being here for most of the webinar. So these are only given through students who sign up through Zoom. And if you miss this one, we give free webinars every single week that have accreditation attached to them. So you can sign up via our website. If you get the Zoom link, that's how we kind of keep track with your emails and know that you were here. So that's really the only way to give an accreditation hour. Also, there's no financial relationships or commercial support I need to let you guys know about that it's going to influence the content. It's just really just about bringing you guys accurate, unbiased education that's going to help you with your board prep, that's going to help you with clinicals. So now that that is out of the way, we can jump over to our learning objectives with what you guys expect to learn. By the end of the webinar, I want you to be able to explain thyroid anatomy. I want you to explain thyroid physiology and know how those hormones work. I need you to recognize the most common autoimmune thyroid conditions, especially Hashimoto's and Graves' disease. We're going to talk in depth about those. And then lastly, we're going to review those key diagnostic findings, emergency conditions, myxedema, coma, thyroid storm, etc. If you guys are studying for your boards, I want you to take note. This is really high yield material. And if you're already practicing, I want you guys to feel really confident when you see these, because like I said, underdiagnosed, 25% of the population has these issues. So it's definitely something you don't want to miss. Okay, moving on to Slido. If you guys have joined my webinars before, you know that we use Slido all the time. And that is how I make sure that you guys are engaged, you understand what we're talking about, and that all makes sense to you. So we will hop over to Slido. You guys can go ahead and scan this QR code if you are joining the webinar on your laptop and have your phone so you can scan. If you are watching the webinar on your phone and you can't scan, just type in slido.com on your computer and then just enter in thyroid disorders, all one word. That will let you join the Slido as well. So I'll give you guys just a second. Once again, you can scan that QR code or just enter you don't have to type in the hashtag, that's already there. So just thyroid disorders. So I will start our very first poll. I want to know where you guys are joining from. Where in the world are you? We usually get a couple out of the US every webinar. I think every webinar I've taught so far, I've had at least one person in the same state as me. So we will see if we have any joining from. I am in Utah today. That is where I am currently living. So let's see where people are at. Oh, I think the answers maybe. There we go. I'm like, why is I see people are in here. I'm not seeing anyone answers. Let's see. Wisconsin, Phoenix. Hey, that's my hometown. My little Phoenix buddy. I hope you are not just absolutely roasting. My husband keeps all the different weathers, and we go to Arizona to visit family a lot, so he always has that one on his weather app, and he goes, wow, it was a really cold day in Phoenix yesterday, only 99. I was like, it's under 100. I bet the people in Phoenix are excited about that. Stormy in Pennsylvania today. New Hampshire. Oh my goodness, Thunder Bay, Minnesota, Florida. We've got a good group there. No one from Utah yet today. Maryland, we got some back Easters. Okay. Awesome, guys. I'm glad you were able to get in the poll okay. Moving on. Now I need to know where you're at in your APRN journey. Do we have students just starting out their program? We're studying for boards already. We have graduated, smashed our boards. Now we're practicing clinicians. Where are we at? Just graduated. Congrats. Congrats. 2 semesters to go. You end is in sight. That's really exciting. That's close. Last rotation, board prep. Okay, guys, this is really good. New grad. Okay, yeah, what month? We're in July. Yeah, so a lot of you guys just graduated probably in like May or June, and some of you guys are just coming up on that. Oh my goodness. I remember graduation being like the most fun thing ever. And I graduated undergrad during COVID, so I didn't get like a graduate. My mom did a really like fun activity for us at home to like make me feel special still. But I was so excited to graduate grad school, and all my family flew out to Tennessee and graduated with us. So congrats, guys. That's really fun. I know studying for boards is not ever the fun way to celebrate graduation, but once you take it, it's going to be like such a weight off your shoulders, and you're going to pass, you're going to use Archer, you're going to pass first time around, and you're going to feel so good. Okay, guys. One last question before I jump in. I need to know how comfortable you are with thyroid disorders. So, scale of 0 to 1 to 10, I think is actually what the scale is. How comfortable do you feel in the clinic, with students, with yourself? Is this something that gets a little confusing to you? You don't know what medication to start him on, side effects to educate on? How are we feeling? Okay, as far as a lot of the webinars I give go, this is pretty good, guys. I'm happy to start out in the 6s and 7s. That means your schools are doing pretty good and you guys feel a little confident. By the end of this, I really hope this is going to be higher. That's what I want. And I do think it will be. Thyroid is my, like, guys, this is my jam. And I know I say that about geriatrics every time, so you guys are probably like, you have too many jams, Annie. But seriously, thyroid disorders, I know. I deal with this every single day. I wake up and I have to take my levothyroxine. So I know the education points. I know what we need to know. Okay, this is good, guys. Oh, don't peek on that. That's the question we're gonna do. Okay, moving on. First thing we need to look at is anatomy and physiology. I need you guys to understand this axis. If you understand this axis, everything about whether something is hypothyroidism or hyperthyroidism, easy peasy. It all makes so much more sense. The thyroid is a butterfly-shaped gland that sits just below your larynx. So it's right here in this box. Normally on a individual that does not have any thyroid issues, it's not something you should see. This is actually how I got diagnosed originally, was because individuals, some doctors I was working with when I was doing some humanitarian work on my doctoral project down in Belize, they noticed it. And so they were like, girl, you have a huge thyroid. We can see it across the bus. And I was like, I have a fat neck. And they're like, no, you have a really big thyroid. And I just kept being like, no, I got a fat neck. Seriously, it's like genetic, having a big neck. And they're like, no, you need to get tested when you get back to the US. And it was, in fact, an enlarged thyroid. So that's how I got diagnosed with Hashimoto's. Like I said, butterfly shaped gland. So it looks like this. It's got its two little humps, two sides, left and right, and it produces T3 and T4. Those are the two hormones that are responsible for regulating our entire metabolism. It's our body's metabolism, our body temperature, our heart rate, so much more. It is a gland that I think everyone talks about neuro, everyone talks about the heart, everyone knows the GI system. We're not talking enough about our thyroid, guys. I just told you it's your entire metabolism, your heart rate, so much more in the body. Healthy thyroids means healthy life. Like, it is just so connected to our quality of life. And that is why I really need you guys to understand this content. So I said it produces T3 and T4. T4 is going to be thyroxine. So that is the inactive form of thyroid. So it's there, it serves a purpose, but it has to get converted. It's just a storage hormone. T3 is going to be the active hormone. So no T4 storage, T3 active. And that's what's actually going to get the job done in your tissues. That's what's going to be your actual metabolism actually affecting your body's organs. The thyroid is regulated by the hypothalamic pituitary axis. So that axis, what happens is when T3 and T4 levels drop, so they're low, the hypothalamus up in our brain says, "Oh, that's not good. Our metabolism hormone's low." It releases TSH, which is thyroid stimulating hormone. I know that we okay, sorry. It releases TRH, which then stimulates the pituitary to release TSH. So it's a little bit more of a stepladder. I'm sorry, I left that out. I just really the two important ones to know there are releases TSH is released from the brain and it tells the thyroid to release T3 and T4. I like to think of TSH. I think of the whole body kind of in terms of this is a production factory, and the brain is always the manager. In every aspect, every system of the body, the brain is that's a person on the floor of the factory that says, "Hey, we need more of this, we need less of this. Hey, have you noticed this?" It is the manager. It is in charge of everything. So our brain, specifically that hypothalamus and pituitary, say, we're getting low. We don't have enough product on the floor. We don't have enough cookies made. We need to make more cookies. So they radio down to the factory makers, which would be our thyroid gland, and they say, "Hey, you guys don't have enough cookies, make more cookies." And that's when our body starts releasing more T3 and T4, which in this analogy would be the cookies. I'm clearly hungry if you guys can't tell. But the big thing to know there is just that it works in this negative feedback loop. So it's the opposite. If the kitchen is really cooking out cookies, there's way too many cookies, our brain says, "Hey, chill out, guys." And so that is when it's going to stop radioing in, and that means TSH would be lower. So you kind of have to understand that loop. It is beautifully designed and it is a negative feedback loop. So high T3 and T4 means low TSH and vice versa. Low T3 and T4 means high TSH. They should always kind of be in opposites. It's really like a thermostat maintaining homeostasis in our body. The first issue we're going to talk about then is when the system goes wrong and we have hypothyroidism, meaning low thyroid hormone, T3 and or T4. Hypothyroidism, that's going to be when the gland is underactive, meaning it's not producing enough hormone. And like I just said, thyroid hormone, way more important than everyone even thinks it is. So what's going to happen is our entire body is going to start to slow down. If you just memorize, I know this is oversimplifying what our thyroid does, but if you think thyroid is metabolism, our energy source, and hypothyroidism then means low energy source, it's going to help you really classify these symptoms over here. It's going to tell you why you should expect to see these things. They're going to be tired, slowed down, brain fog, weight gain, their metabolism slow. They're going to have dry skin, brittle hair. That last third of their eyebrow hairs is usually gone. Their puberty is going to be late, which I never thought anything about, but I didn't start my cycles until I was 16, almost 17 years old, which if you guys have taken your female anatomy course, you would know that's abnormal. That's not normal. You have heart palpitations. They can feel really and they can feel anxious or depressed. Depression is going to be a lot more common. I like to think of anxiety as hyperthyroidism. So depression is really common, especially when you're talking, this is in women that are 35 to 40. They're usually moms at this point, and or they've got a full-time job. And can you imagine anything more exhausting than your metabolism being so slow it's barely functioning to keep your body alive, and then you have to go to the gym, you have to cook dinner for your family, you have to clean your laundry, you have to go to your full-time job. It's just so overwhelming. It really leads to depression in a lot of these women. And the key thing to know here is that these symptoms, they're all really non-specific. I mean, every girl in the world thinks that they lose weight less than the other person. I mean, it's just the way we're like, yeah, my metabolism's slow. Sandy down the street, she loses weight so easy, but for me, it's impossible. And so a lot of doctors write this off as it's just like, she eats too many calories. She's got 4 kids. No wonder she's tired. And so that is why we as APRNs need to maintain a very high index of suspicion, especially in women, because it's way more common in women, because they're disproportionately affected, and we need to keep our radar up and make sure that we're not missing this. Diagnosis, of course, is going to be done with a blood test. You're going to first notice off their characteristics. Anytime a woman or a man comes in and they are telling you they've got a list of these symptoms, you should be testing their thyroid hormone with a lab test. Specifically, we test TSH normally because, like I said, TSH is the manager. It kind of controls everything. We start with TSH, and usually you'll order what is called a reflex T4, meaning if TSH is abnormal, then the lab will also look at T4. If TSH is normal, we just say, okay, chances are T4 and T3 are also normal. So with that, what you're going to see with hypothyroidism is their TSH is going to be high, remember, because the brain has noticed, hey, we're not pumping out enough cookies. We need to make more cookies. So it's trying to tell the thyroid hormone, make more cookies. But the thyroid is damaged. It can't produce as much. Ovens are down, KitchenAids aren't working, and it can't make the cookies that the brain is telling it to make. So then you're going to see that low T4, low T3. That is what was diagnostic for me, along with these TPO antibodies, which is specific to Hashimoto's thyroiditis usually. So as we look at causes, Hashimoto's, like I said here, is the most popular cause. That is an autoimmune thyroiditis, is another word for it. It means your body has created antibodies against our thyroid hormone. They think this can happen for a lot of reasons. We know it's highly genetic. They think diet may play a role. They think environment, stress, all those things can play a role as to why our body attacks its own thyroid. It kills the tissue, makes the tissue really inflamed, and therefore the tissue can't make as much T3 and T4 as it would normally. Other causes, and I kind of group these here together with a bracket for you guys, are going to be things that damage or remove the thyroid. Of course, your T3 and T4 are going to be low if we have damaged our thyroid with radiation, if we've damaged our thyroid with surgery and took it out. I mean, the brain could tell our body all day long with super high TSH that it needs more T3, it needs more T4. If you don't have a thyroid gland to make T3 and T4, you're just not going to have effects from that. So those are going to be kind of the big ones. Those are all considered primary hyperthyroidism. That means the issue is at the thyroid gland, the primary issue. Secondary hypothyroidism is going to be issues in the brain. So that's going to be where TSH is off. You should know this and be able to differentiate between primary and secondary, but I would say as a caveat, secondary hypothyroidism is pretty rare and usually diagnosed by like an endocrinologist. In family practice especially, primary hypothyroidism is going to be what you see on a day-to-day basis. Moving on to Hashimoto's disease. Like I said, this is the most common cause of hypothyroidism, and it is going to be in those iodine sufficient regions. It is an autoimmune disease, like I said, attacks the thyroid gland, and then over time you have reduced hormone production. That means Hashimoto's thyroiditis is progressive. There's a lot of people saying out here right now, like if you eat a certain diet, if you stop gluten, if you stop dairy, if you eat the autoimmune protocol diet, you'll cure your Hashimoto's. There is not enough evidence-based practice out there right now for me to say that that is true. I will tell you right now, all the evidence supports that Hashimoto's is a progressive disease. It gets worse. And so that means you're going to have to up the dose of medication or treatment for that individual throughout their life. So right now I'm on a certain dose. They've upped my dose twice since I've got diagnosed, and it will continue to get higher and higher until finally my thyroid gland is mostly dead because it's attacked itself for so long, and I will just be then on just a regular dose of thyroid for the rest of my life that is what is based off my body weight. Other things to know, Hashimoto's does affect women far more than it does in men, and you often see it with other autoimmune diseases. So individuals that have lupus, individuals that have type 1 diabetes, they're at higher risk for developing Hashimoto's thyroiditis. It doesn't really work the other way. So if you have Hashimoto's thyroiditis, you're not more likely to get lupus, but if you have lupus, you are more likely to get Hashimoto's thyroiditis. Couple pearls for you guys to know. Remember, TSH would be elevated on this blood test. Their T4 or T3 is going to be low or low normal. And most of the time, we will diagnose Hashimoto's thyroiditis based off of a couple things. First off, that they have TPO antibodies. That's going to be positive in about 90% of the cases. So, 1 in 10 people don't have TPO antibodies, but still have Hashimoto's thyroiditis. But in the vast majority, they do have the anti-TPO antibodies. So that means their body is attacking their thyroid. That's a really good way to diagnose it. For me, for me personally, my TSH was very, very high. meaning my brain was saying that it needed to pump out a lot more cookies, but my T4 was low normal. It was low, but it wasn't super low that was concerning. What that means, especially at the beginning stages of the disease when they're getting diagnosed, is usually that their thyroid is not so damaged that it can't keep up with production. Like their manager is yelling at them. It is pumping out so much TSH saying, make more T4. And it can keep up with that kind of. So it's going to be on the low end of normal, or it's going to be a little low, but maybe mostly normal. And all that means is that the thyroid hormone is trying really, really hard to put out enough hormone, but it just can't really keep up with production. The thyroid may feel firm, enlarged, nodular palpation. That was the first thing I went to my primary care provider. He palpated my neck and was like, yeah, your thyroid is very swollen. It's palpable and it shouldn't normally be that palpable. And he immediately got me an ultrasound for my neck where they measured it and said, yeah, your thyroid's like 4 times the size it should be. And I was like, okay, this is good to know. I don't just have a fat neck. It is actually a medical issue that needs to be treated. That is kind of the big things to watch out for Hashimoto's disease. Other thing is going to be to watch out for myxedema coma. And myxedema coma is the most severe form of hypothyroidism. It is considered a medical emergency. So this is when their thyroid hormone is so low that their body literally can't keep them alive. It is so dangerous, and we really need to be able to recognize it because most of the time they'll present first to their primary care provider. And even with treatment of a myxedema coma, if it's to the stage where it's being diagnosed as that, it's a 30 to 60% mortality rate. So early intervention is really key for this. Some triggers to know, and the most common cause is going to be just that they obviously have hypothyroidism and have for a long time that either they haven't been treating or has been undiagnosed. And like I said, with Hashimoto's, the thyroid continues to get worse. When I was diagnosed, I had, normal low. I was really like on the low end, pretty much considered low with my T4. But for the most part, my body was trying to keep up with it. If I hadn't been diagnosed for another 30 or 40 years, my thyroid would have died off so much. My T4 would have been so low, you would see something like this. Other triggers that can cause it in someone who maybe is getting treatment for their thyroid already, but their body just needs more thyroid hormone than normal. Pregnancy, MIs, strokes, trauma, severe traumas can cause it if they just stop their thyroid med because they ran out and they didn't have insurance, couldn't get more medication. All of those can cause issues. Lab findings for this are going to be your TSH is elevated. Obviously, you're going to see pretty high TSH, but the big number that is going to be off is your T4 is going to be so, so low. That is going to be just like nearly non-existent. And you're going to see some other lab findings with that, like hyponatremia, hypoglycemia, elevated CK. As far as assessment goes, they're going to be really confused. So this will be someone who their loved one brings them in and they're like, they can't get out of bed. They're running really cold. They just have to be covered in blankets. Their heart rate's low. They're just really confused. And you're going to see all of those on assessment along with hypoventilation. They don't breathe very much. It leads to respiratory failure, hence the coma aspect. And then non-pitting edema, hence the myxedema part of the myxedema coma. You will see non-pitting edema. And like I said, we need to get them to we need to get them to a hospital as soon as possible. They'll treat with IV levothyroxine, they'll treat with steroids, and they're going to require really an ICU supportive care level. So do not miss those. Okay, back to just regular hypothyroidism, not medical intervention for ICU, just run of the mill like I had. Hypothyroidism. How do we treat it? It is levothyroxine, synthetic thyroid, synthetic T4. We don't need to give it in the active version for almost all of your patients because the body can normally convert that T4 that you're giving it into T3, even if the thyroid's dying with, Hashimoto's, etc. So with that, what you need to know is that this is very treatable, very manageable. And that would be the first thing that you tell your patient. I remember I was in grad school when I got diagnosed with Hashimoto's, and I laid in bed for like 3 days. I was so sad about it. Like the fact that I had this autoimmune disease and I needed to take a pill every single day for the rest of my life. Getting my thyroid treated, guys, best thing that ever happened to me. Literally. It changed my life. I felt so much better. I didn't even know, I wouldn't have told you that I had these symptoms. Like, I wasn't complaining to my mom and family every single day that I'm so tired, I can't get out of bed, or I'm so depressed, I'm so constipated, my hair is dry. I just felt like I was like every other girl. Like, I had a really hard time losing weight. And I felt like I was eating, like, I would track my calories and I was eating like 1,000 calories a day and exercising, and I was not losing weight. I was just at my weight. And it was because my body didn't have enough of the hormone that it needed. And so with that, I got put on levothyroxine and I really saw results. It does take about 4 to 8 weeks to see those results. And the goal of treatment here is just to obtain a euthyroid state. So we have medically been able to create a medication, levothyroxine Synthroid, that really mimics the exact thing that our body makes normally with a thyroid. That's why people can have a total thyroidectomy where their entire thyroid comes out. We kill the entire thing off, we take it all out, and they can live an entirely normal life because they just take a high dose of Synthroid that would be what their thyroid gland would make normally if it hadn't been removed. So what we're trying to get is those euthyroid states. The problem is the thyroid hormone loop, that negative feedback loop, does take a while. And so we wait about 4 to 8 weeks after changing doses, after starting a patient on a dose to test labs. So if I start them and I test them 2 days later, I'm not going to see a change in results. That takes that about 4 to 8 weeks. So that's something really important to know. So you know when you should be checking in after adjusting a dose or when you should be checking in after starting a dose. The patient also needs to really be counseled on taking that medication because, like, for example, my grandma also has Hashimoto's thyroiditis. Once I got diagnosed, I was talking to her about it and I was like, oh, I mean, one of the hardest things about being diagnosed with this is that I just can't ever eat breakfast because I don't wake up early enough to take my thyroid hormone, wait an hour, eat breakfast, and still make it to work on time or go to the gym, etc. And my grandma's like, what do you mean? I take mine with breakfast every day. She has been on thyroid hormone, guys, for 50 years now. And no one had ever told her that she needs to be taking that at breakfast. So we got her taking it right. Her thyroid levels finally chilled out. They had been all over the place. They'd been having a really hard time managing it her whole life. And it was because she wasn't taking it properly. So that patient education is key. The reason we have to take it 30 to 60 minutes before we eat on an empty stomach is because I like to call thyroid hormone really, really fickle. It is, it's just kind of a big hormone. Like, it does not absorb if there's anything else in the stomach, especially if there's calcium or antacids or taking a PPI like omeprazole, etc. It's just like, well, you know what? I'm not absorbing today. It does not share stomach space well. And so it needs to be taken on an empty stomach so that it can absorb properly. And then about an hour after that, you can have breakfast, lunch, whatever. And about 4 hours after that, you can take other medications that contain iron, calcium, take a Tums. One of the things I have to remind myself is that I can't take my multivitamin because my multivitamin contains calcium and it contains iron. And it's really easy as a patient to just take all those things at the same time. Take all your pills at once and call it good. But that needs to be at least 4 hours apart. So I take my thyroid hormone first thing in the morning and I take my multivitamin in the middle of the day, more right before dinner-ish. Once that desired form like dosage is reached, that's going to be when you see TSH has kind of chilled out. We know this is a good dose for them. And then you monitor labs about every 6 to 12 months. So every 4 to 8 weeks after changing a dose, and then every 6 to 12 months after stabilizing that dose. You also are just going to want to monitor, have patients report to you any change in symptoms. So if all of a sudden they start feeling really tired again, they start feeling really constipated, maybe their dose needs to go up now. Or same thing on the other side, they start having heart palpitations, they're really anxious, really sweaty, heat intolerant. Maybe that dose is too high for them and they are hyperthyroidism. One of the things to note is that when I started treatment, I lost a lot of weight. My metabolism was finally more normal. I'd been under eating for years. And so I lost a lot of weight quick. And one of the things my endocrinologist wanted to monitor with that was thyroid hormone is weight based. So the initial dosing, like I said, age and weight based. I lost a lot of weight. She maybe was going to need to bring down my hormone. But with the way my thyroid was working, we actually upped my dose. But in most patients, if they lose weight that or gain a lot of weight, that's going to change how much thyroid hormone they need, and you may need to adjust dosage. So know that. Last note of treatment that I want to talk to you guys about is that pregnant or lactating. Pregnant or lactating females, they have higher dose requirements. Our body needs a lot more thyroid hormone when we are pregnant. Around 12 weeks, that's when our baby's thyroid starts to work on its own, but it doesn't even make enough to really support itself until 20 weeks. So that first 20 weeks of pregnancy is crucial to make sure that the female is getting enough hormone both to support herself and to support the baby that she's growing. So something really important to note there. As we look specifically into the pharmacology of the medication, I want you guys to know the mechanism of action is identical to T4 that our body makes naturally. So it is just an actual replacement of the hormone, keeps it really simple there. Big things to note for adverse effects that you want to educate your patient about. These are normally, all of these adverse effects are because we have too much in the body. So there are no negative effects of levothyroxine, Synthroid, which is the brand name, if you're taking the right dose. Adverse effects all come from having too much of the medication. So that's going to be where you see anxiety, heart palpitations, heat intolerance, hyperthyroidism. Those are all just going to be because they're on a medication that's identical to what our body already makes, but it's just too much. So they're having the symptoms of hyperthyroidism. Hyperthyroidism really isn't contraindicated in anyone. I would say we never take someone off of it because it is, chemically identical to what our body makes. There's really no reason to take someone off of it, but we may take them off of it for a little bit if we think, hey, maybe there's an underlying issue that we're worried about, like thyroid nodules that may be cancerous. If they have a history of an acute MI, we may drop their dose down a little bit because of that risk for heart palpitations and anxiety, which increase the risk of further MIs. But other than that, no acute contraindications. I've never heard of anyone being allergic to levothyroxine since it is identical to what our body already makes. Monitoring parameters, like I said, remember, we're monitoring that every 4 to 8 weeks after we change a dose, and then every 6 to 12 months just as continual monitoring. Education, we already kind of went over these. They need to swallow it whole and take it on an empty stomach, and then 4+ hours in between any other calcium or iron containing medications. And then we also want to tell our patients never to stop this abruptly. I mean, if they miss one day, it's not going to send them into withdrawals, but their body is on this because it doesn't make enough on its own. And therefore, we want to keep them on this every single day, taking it the right way. That's going to have the best results. We really don't want them to just go off this on their own. Okay, guys, we are ready now to jump into some practice questions. And I made sure, I know last time you guys wanted more practice questions, so I've put a ton in here. Let's take a peek. A patient has been diagnosed with hypothyroidism. They began them on levothyroxine 25 micrograms. In review of the patient's current medications, which of the following are you going to have to give them special education about using concurrently with levothyroxine? It's going to be omeprazole, escitalopram, atorvastatin, or lisinopril. Just as a refresher, lisinopril, that's that blood pressure med. ACE inhibitor, atorvastatin, that is a statin. Escitalopram, that is an SSRI. And omeprazole, that is a PPI. So let's check it out. What do you guys think the answer is? Hop back in that Slido using that QR code or that hashtag thyroid disorders. We've got some answers coming in. Omeprazole, also known as Prilosec. Oh my goodness, you guys have all answered the same answer. No one's going to put a wrong answer in for me. Yep. I am a very good teacher, and you guys are very smart students, is what I am learning. That is great, guys. Exactly. The answer is A. Synthroid needs to be taken on an empty stomach, like we said, 30 to 60 minutes before breakfast, but 4 hours in between your Synthroid and other medications like calcium, iron, PPIs, etc. So that is going to require very specific education because of that 4-hour window. All of those other medications can't be taken with Synthroid, but just 60 minutes after, 30 or 60 minutes after you take your levothyroxine, you can take those other medications. Omeprazole was the only one that requires specific education because of that 4+ hour window. Okay. Another practice question. They know that congenital hyperthyroidism must be identified quickly after birth to prevent irreversible neurological effects. Which of the following is the standard of care that has helped identify the diagnosis earlier? Is it pulse oximetry, thyroid ultrasounds, newborn screening, or hearing screening? Let's hop over to that one. If you guys are jump back in that Slido, we'll give you guys a couple seconds to put in your answers. This is more of a tricky one because I didn't say this one overtly. As you guys are answering this is something that my uncle, I told you guys, low thyroid really runs my family. I think every single one of my aunts and uncles on both sides of my family has it. I was like screwed genetically from the start. My uncle was born, and the year he was born was actually the year that they started adding in checking thyroid in newborn screening. Newborn screening it's a state-run healthcare initiative, so it does vary state by state a little bit, but in all of the 50 states and in DC, Checking the newborn blood for thyroid is standard within that 24 to 48 hours. It's going to screen for those metabolic issues. And my uncle was one of the first ones in Montana, where he was born, to be diagnosed with congenital hypothyroidism. And congenital hypothyroidism, when it is undiagnosed, leads to learning disabilities. So our thyroid hormone is so important in the development of our brains. Those babies, if they don't get it within that first little bit of that newborn period, have a lot of learning disabilities and tend to be to have some intellectual issues long term because of it. So it was like a big miracle in my family that, 2 weeks after they start testing thyroid hormone in Montana, my uncle was diagnosed with it. So they caught it really early because of that. So really important that this is something we educate patients on during pregnancy and after, why they should get newborn screening. Last practice question here for hypothyroidism. Which of the following causes the majority of hypothyroidism in geriatric patients? So we're shifting to older adults. If they're 65 and up, they show up with fatigue, weight gain, sluggishness, and you're thinking hypothyroidism. What is the cause? Why are we thinking there's an issue? Can be post-surgical, after radioiodine, which is one of the ways that we kill thyroid without doing surgery. Is it autoimmune thyroiditis, also known as Hashimoto's? Secondary thyroiditis? Is it a brain issue? What are people thinking? Looks like the vast majority is saying autoimmune thyroiditis, and that is accurate. The majority of hypothyroidism in geriatrics is due to that autoimmune thyroiditis. It's also the cause of younger patients. So regardless of age, it's autoimmune that is the most common issue. Remember that secondary hypothyroidism, I know that that is what people were saying. This is a really rare cause. That is when there's an issue with the pituitary gland or with the hypothalamus. That is not very common to see frequently. Patients that are struggling with like a brain tumor or something, that would be a more rare cause of hypothyroidism. Okay, real quick break before we dive into hyperthyroidism. I want you guys to have access to our social media pages, access to SurePass, join our community. I want you guys to know what we offer. I know we do a lot of free webinars for you guys because we know how important it is. But outside of that, we made sure that we kept pricing across the board for our APRN products really, really fair. We are all APRNs ourselves, and we all remember what it was like to be living off top ramen, to be poor and starving and stressed out of our mind and trying to get clinical hours in, but also you're probably working part-time as a nurse and trying to provide for your family or for yourself, and it was stressful. So you can sign up here for our SurePass combo. We do a lot of deals on that, and this I would say is our best deal because this comes with our whole Q bank, which is over 1,600 questions with our readiness predictor. It comes with all of our and-demand videos. We have thousands of hours of videos there that we're adding to and improving on constantly. You get access to the 3-day live review, and you get access to mentoring. So it is really everything you need. There's a pass guarantee that you will pass first time around using this. So that is going to be your best way to just feel confident going in, especially for you guys that I saw are studying for your boards right now. Other things, if you are getting close to your boards and you just want a little bit of help, our Q Bank, I can't recommend highly enough. I can say firsthand that that is what I used to study. I used the Archer Review APRN product. I passed first time around. Going into the test, I felt very confident. The questions are hard. They're always going to be hard. Every time you take a test like the NCLEX or boards, you're going to be stressed about it. But I left knowing I passed. I was like, yep, I've got this. Like I'm an APRN. So can't recommend that enough. Our Facebook group, I post questions on there daily for you guys. Instagram, these are all going to be great ways for you guys to find about our free webinars, about our paid webinars, about products we're offering. We're constantly improving, building out new things. So scan this QR code here to join our community and get in on there. Okay, jumping back to hyperthyroidism. This is the opposite problem. This is going to be when your thyroid is pumping out too much hormone. So everything speeds up. They're going to be jittery. They're going to be anxious, sweaty, losing weight rather than gaining weight. They're eating more, but they're still losing weight. That is highly indicative to me that maybe there's a thyroid issue, that your thyroid's a little high. They may have palpitations or tremors. They may even complain of things like they're hot all the time. They're always sweaty. They have frequent bowel movements, a lot of diarrhea, and they can't sleep at night. In women, it can also cause irregular periods, and in older adults, it can cause AFib. So this is something we definitely want to catch. It's not as common in the United States as hypothyroidism, but it is still pretty common. So you want to make sure that you are able to recognize this in clinic. This is the exact same feedback loop we just talked about, but it's flipped this time. So what you're going to see in hyperthyroidism is that T3 and T4, the kitchens, the cooks in the kitchen, they have been baking. Like they're pumping out cookies, and the manager is like, we don't need this many cookies. People are not buying enough cookies. Please stop making cookies. So they're sending out a lot of announcements for the kitchen to stop making cookies, and yet they are not. So that's going to be why you see low TSH, and T3 and T4 are going to be very high. It's churning out hormone nonstop, and TSH, that manager, is essentially being ignored. That's going to be the key pattern to recognize in that negative feedback loop, because it's going to help you interpret those labs really fast. So when you see it and it says high T3, T4, low TSH, you know immediately this is hyperthyroidism. Most common causes of hyperthyroidism is going to be Graves' disease. Graves' disease is the opposite of Hashimoto's disease, but kind of the same because it is autoimmune thyroiditis. This side, it's making too much. So it's just that opposite spectrum. Your body's attacking its thyroid, except for now your body's response to being attacked is it's just making way more because it's under attack, and it is just pumping out T3, it's pumping out T4. Most commonly, you're going to end up on the Hashimoto side, where because your body's becoming attacked, it just checks out and it stops making T3 and T4. But for some individuals, they'll end up on that other side, and that's going to be what Graves' disease is. You also have toxic goiters, you have toxic nodules, you have benign adenomas. You can have an actual tumor on your thyroid gland that makes its own thyroid hormone, and that's why it's high. And metastatic thyroid carcinoma is also going to present with high thyroid. So a couple different causes for this one, but once again, like I said, Graves' disease is the most common. Secondary hyperthyroidism, just going to be like secondary hypothyroidism, except for on this side, it's going to be a tumor specifically on that pituitary gland, that pituitary adenoma. Way less common though. So when you're seeing a patient, I don't want the first thing you guys to jump to be like, oh, it's a pituitary tumor, because that is far less frequent. Symptoms, like we said, are going to be the same symptoms you saw when you had a patient on, Synthroid and you have them on too high of a dose. So it's too much thyroid hormone. They're going to be anxious and irritable. Their heart rate is going to be high because when they have hypothyroidism, their heart rate is low. I would say, guys, the easiest way to remember the symptoms of hyperthyroidism and hypo, like I said, is to think it's really slowed down or it's all revved up. That's going to be your easiest way to remember the difference between these two, because that is a very common board question. Is like, they'll give you a clinical presentation of something like this, and you have to be the one to be like, hey, is this hyper or hypothyroidism? So understand the difference between those two. And diagnosis then on this one, think about this logically, guys. Like I said, we always diagnose with a blood test. So TSH, T3, and T4. What do you guys know with that negative feedback loop? Your labs are going to show very low TSH because the manager is saying stop baking cookies, and then very high T3 and T4. What you're going to want to consider here is ordering thyrotropin receptor antibodies. That's going to be kind of what you see with Graves' disease. That can help diagnose as well. And you may want to do radioiodine uptake scans. That is something that endocrinology will usually order, not in family practice, but that helps distinguish if it's Graves' disease versus other causes like goiters and nodules. So if you got that first step lab back and you found out, okay, yeah, their TSH is really, really high, their TSH is really, really low, and their T3 and T4 are high. What's the cause? What's the underlying issue? The radioiodine uptake scan is going to be kind of where you differentiate those two. Like I said here, Graves' disease is the most common. So this is the hyperthyroid poster child. And what makes it very distinctive is going to be that diffuse goiter. They're not going to really have nodules. Nodules are a lot more common in Hashimoto's disease than in Graves' disease. And of course, that thyroid eye disease. This is what is diagnostic really to me. It is this wide eye look where they look kind of scared or startled all the time. Their eyes are bulging a little bit, and you can see the whites above their eye. So normally when someone is normally sitting, our eyelids rest upon that, and we can see, kind of the bottoms of the whites of our eyes, but you don't normally see the tops. If you can see the tops, that is what we really consider exophthalmos, and that is very indicative of hyperthyroidism. I wouldn't say I diagnosed because I wasn't his provider, but I was watching a basketball game with my brother, and the Phoenix Suns were playing, I think. And there was this guy on the court, and I was like, James, pause that right now. He pauses the TV, and I'm like, that guy has hyperthyroidism. He should get that checked out. Like his eyes are, he's on the court playing basketball, dribbling, and his eyes are just bulging out of his head. And I was like, who's that guy? My brother tells me the name of this basketball player. I look it up. Yes, he has known hyperthyroidism just in the last couple months that they were working on getting treated. And I knew immediately based off of that thyroid eye disease. Another fascinating finding is that pre-tibial myxedema. So they'll kind of have that edema just right above their tibia. It's weird. You're only going to see it a few times in practice, but once you do see it, you'll never forget it. So if you see someone come in your clinic, they're jittery, they got big eyes, swollen neck, I want you guys to immediately be thinking, this is Graves' disease. How are we going to treat Graves' disease then, or really any form of hyperthyroidism? This one is a little bit harder because it was so easy. We have created synthetic thyroid hormone. So for low thyroid, all you have to do is take that hormone replacement. Hyperthyroidism, on the other hand, is more symptom control. Our first step with managing hyperthyroidism is treating those symptoms. Those symptoms are awful and really dangerous. We don't want our patients to be walking around anxious and tachycardic. That's like a risk for a cardiovascular event. So we manage our symptoms first. Usually we do that with beta blockers like propranolol. That can really help dampen that adrenic surge that you get with too much thyroid hormone. And then we talk about other definitive treatments. So how are we going to make the thyroid stop making so much hormone? At this point, unfortunately, our best plans have been, okay, so how do we make something that is making too much hormone make less? I mean, TSH is already low. The brain is already kind of told it like, hey, stop making hormone. Like, we're not giving you the signal to keep making hormone. So TSH is really low. So what else can you do? Like, we can't make TSH lower, and clearly the thyroid's not listening to the TSH. So what do? What we have figured out is we just said, okay, well, if we kill the thyroid, what if we make it so the thyroid can make nothing? What if we kill the gland, we take the gland out, and that's kind of what we have figured out so far. And that's the funny thing about medicine sometimes. And maybe they'll figure out a different thing, but we know it's so easy to treat hypothyroidism. So, really, what they do is they will use drugs like methimazole or PTU or a thyroidectomy. That methimazole or PTU, those are considered anti-thyroid drugs, ATDs. And it's pretty easy if you look at the name anti-thyroid drug, they kill the thyroid. So, it is damaging to the thyroid. And when you take it, then hopefully you kill some of that gland that's making too much hormone and you can kind of stabilize them out to a normal level. Remember though, methimazole is not for the first trimester of pregnancy. It is it's an abortifactant. I can't remember the word for that, but it kills babies. So we do not use methimazole during the first trimester of pregnancy or in anyone who's even trying to get pregnancy. Or trying to get pregnant. We don't use that one. That is where PTU comes in. So remember for your boards, the antithyroid drug that starts with P, that is for pregnancy. So PTU, pregnancy. That's how I remember that one. You're always going to want to refer out hyperthyroidism to endocrinology if there's eye involvement. Ophthalmology is also going to need to be involved as well. You're going to want to look at visual impairment. This can lead to heart failure over a long time because our body is constantly having this adrenic surge that can lead to left ventricular hypertrophy, AFib, etc. So you're going to want to monitor for heart stuff. Usually a cardiologist will be involved in this as well. The other treatment option that I was talking about was thyroidectomy. And specifically with the thyroidectomy, what we're doing is we're taking out part or all of the thyroid gland. Sometimes they'll just start and take out part of the thyroid gland and then hope that like 3/4 of a thyroid gland that's working at 150% and producing too much hormone will then lead to a normal amount in a regular adult. Or sometimes they'll just take the whole thing out and then they'll just put them on thyroid supplement. So my aunt is a great example. You are like, Annie, you have so many family members with thyroid issues. My aunt had Graves' disease. So she was diagnosed in her 20s or 30s with Graves' disease. What they did is they put her on radioactive iodine. So they did the radioactive iodine therapy. And just like it works in cancer radiation, it kills the thyroid gland. So it's targeted specifically for that gland, killed it off. And now she is considered to have hypothyroidism because she used radioactive iodine. So they killed off most of her thyroid gland. Her body now can't really produce any thyroid hormone. And now every single day she takes levothyroxine. So since they know it's such an easy way to treat there, that was what they did. It's got to have been like 20 plus years ago now at this point. Now we're going to zoom in on thyroid nodules, and we're talking about thyroid nodules here because usually thyroid nodules will contribute to hyperthyroidism. Remember, it is one of the causes of hyperthyroidism. And what you need to know about this is that half the population has a thyroid nodule by the age of 60. So most of them are benign and found incidentally, just during a routine head to toe. They're palpating the thyroid and they say, hey, yeah, this feels a little weird. They go and get an ultrasound and they find the nodule that way. But it is our job as primary care providers to screen for malignancy, because while half the population has them by age 60 and they are mostly benign, I think it's about 90% of thyroid nodules are benign. You still want to know if it's benign or not. And so, what you're going to do to screen for malignancy, the first thing you're going to do is get a TSH level. So, if it's low TSH, you should be thinking it's a hot nodule. And then you're going to want to follow up a hot nodule with radioactive iodine uptake scan. If TSH is normal or high, now you're thinking that it's a cold nodule, meaning it's kind of contributing to hypothyroidism, and you're going to want to get a thyroid ultrasound. I am the perfect example of this, along with my aunt that I was just talking about. My aunt got diagnosed with hyperthyroidism, not because of all her symptoms she was having. I mean, what girl complains about it being hard to put weight on? Like, no girl's like, I should go see my doctor. I'm losing weight and I get to eat whatever I want. Most people think that's awesome. I'm gonna live with that. I was on the opposite spectrum. And so both of us went to our primary care providers 20 years apart. Her primary care provider felt her neck, felt something that felt weird, felt a nodule. He got her TSH. Her TSH was way low. So he was thinking, okay, this is probably a hot nodule, meaning it is hyperthyroidism. He sent her for the radioactive iodine uptake scan. They recognized it's Graves' disease. They put her on radio iodine therapy. Me, on the other hand, primary care provider feels a nodule, says, this is weird, sends me off, gets my TSH. My TSH is sky high. And they sent me for a thyroid ultrasound. The thyroid ultrasound showed, yes, this is a cold nodule. It's benign. We're not worried about it. So that's going to be kind of how you differentiate whether or not you've got malignancy, whether or not you're worried about something, and how you're going to treat it. Anytime you are worried about a nodule, you're going to want to refer that out to endocrinology. Endocrinology is going to be the one to decide, hey, should we do the radioactive iodine uptake? Do we want to do fine needle aspiration? Do we want to do a biopsy? Do we want to take their thyroid out? Because better safe than sorry, we think it's definitely cancerous, etc. So endocrinology is going to make all those big decisions. You just really need to identify whether or not you think it's a hot nodule or a cold nodule, and how soon you want to refer out. What is your worry about that nodule? Are you really worried for malignancy, or you're less worried for malignancy? Then we want to talk about the hyperthyroid emergency, which is the thyroid storm. This is myxedema coma's equivalent, but on hyperthyroidism side. So on the opposite end of the spectrum, this is where myxedema coma, everything was so low they were dying. On this side, everything is so high they're going to die. Mortality can be up to 25% even with treatment. And triggers are going to be same things: childbirth, infection, trauma, surgery. If you looked at the triggers and stressors for a myxedema coma, it's the exact same things. So clinically, what you're going to see here symptoms are agitation, tachycardia. They're going to have a fever, and potentially they may be even having some seizures or be in a coma. Once again, this is an ICU level situation. They're going to need to be on IV medications like propranolol to lower that heart rate, to prevent heart attacks, to prevent strokes, and you need to get them to an emergency department as soon as possible. Now, I have a couple practice questions for us on the hyperthyroidism side. So let's see. 32-year-old patient presents to the NP's office with complaints of unintended weight loss, palpitations, thinning hair, insomnia. She's speaking with the nurse. They note her eyes are kind of protruding, vital signs. Blood pressure looks pretty good. That's not bad. Heart rate's 114. We got tachycardia, respiration's 18, and temperature is 98.1. What diagnostic test does the nurse practitioner consider to further assess these symptoms? What is going to be your next step as an NP? What are you going to order? TSH, T3, and T4 is what most people are saying. In fact, that's what everyone is saying. Answer is right. They have a lot of symptoms that we're thinking, okay, this is Graves' disease. And with that, we always start with that lab test. Is the first thing we order is we order that TSH, T3, T4, and possibly even that antibody, the thyroid antibody test. So we will start there. These other things may be things we want to get at some point to look at it, to, rule out other issues, but we always want to start with that TSH, T3, and T4. Next, what medication for the treatment of hyperthyroidism is contraindicated in the first trimester of pregnancy? Methimazole. Exactly, guys. Methimazole is an antithyroid agent. It inhibits the synthesis of it, but it does that by blocking oxidation. And so with that, it's going to cause severe abortions or congenital abnormalities in the in newborns. So we do not give this to any woman who's trying to get pregnant, who's of childbearing age, without making sure that she knows they should be using two forms of birth control. Instead, remember, we use that PTU. That is the antithyroid choice for pregnancy. Okay, and let's see. Moving on here, we've got just a couple more minutes. I want to end here with option for you guys to have a Q&A. What is currently bothering you guys? What questions do you have for me? Is there anything you guys want to know more about that I did not, that I confused you about, or I didn't go in enough depth about? At this point, you guys really should have the knowledge you need to assess, diagnose, treat effectively thyroid disorders. That's all in your APRN scope. Keep reviewing case studies, keep looking at practice questions. Like I said, our Q Bank has a ton of endocrinology questions. I know that is those loops, those negative feedback loops or positive feedback loops, etc., can be kind of tricky. So we made sure the Q Bank has a ton of questions in there for you guys in varying levels of difficulty. Can you have your art people do a picture of pretibial edema? Yeah, I do not think we currently have one in our brand folder for that. Let me write that down as one to illustrate for you guys. They are awesome, those medical illustrations. Yeah. Okay. I wrote that one down. Thank you. And then real quick, while you guys are still in here, I want to know, how comfortable do you now feel with thyroid disorders? We were kind of at a 6 flat. I think it dropped down to a 5.5. How do we feel now? Did talking about that, really the feedback loop is going to be where you get tripped up the most. If you guys can understand the feedback loop and know that high TSH, low T3 and T4 is hypothyroidism, and then low TSH, high T3 and T4 is hyperthyroidism. If you guys can understand that, you will feel so much more confident in thyroid disorders, I promise. Okay, that's good, guys. I'm happy with a 9. A 9 is really good. Okay. And then lastly, what else do you guys want me to do a webinar on? This was a new one that someone requested, that I talk about thyroid disorders because they were struggling with that. What else do you guys want? We really tried to take your opinions. If there's a webinar that you guys feel like we're not doing yet that you would really like to see or you'd like to see more of, let me know. You guys can put your comments in here or you can email me directly and I will put it into content development. Coding and billing, I've gone that one every single time I've done a webinar, and they're building it out right now. It's just one of those things where insurances are also different. How people code and bill varies clinic to clinic. So we're trying to get you guys the best evidence based off of practice, and getting, good information for you guys. Non-demand 3-day live review is something that we are working on here to get as just a viability for you guys. We want to make sure it's a really strong recording, but we understand, like I said, most of you guys are still working part-time or full-time, and maybe having 3 days of your life just to sit down, maybe what the 3 days we pick don't work with your schedule or your kids or your family, work, etc. So I want to get you guys a version where you can download it on your own, just buy it and download it. And then also on the other end, I want you guys, if you want to, the live interaction, the chatting, we're getting a 3-day live review put on the calendar as soon as possible for you guys. Friday through Sunday. I'll write that down. People always like to hear this in our meetings. What do the students want? Maternity, derm content. We have a maternity APRN on our team here who's so amazing. I'll ask if she can get a maternity one on the calendar for you guys, because that is one of, like, neuro issues always make me anxious, and so do maternity issues, because it's like, okay, if I mess up a neuro issue, like, they're gonna die or be paralyzed, and if I mess up a maternity issue, like, their baby may die. So those ones always stress me out a little bit when I'm treating those patients. So it is something you definitely want to be confident in, and you don't get as much practice in. So I will make sure I get those. And then just ending for you guys here again, I will leave this page up for you guys. with the link to schedule SurePass and this link here to join our social community. We've got on-demand videos, question bank, SurePass. We launched our clinical skill videos recently. That's going to be an on-demand where you guys can watch us suture. I mean, when I was in grad school, I swear the suturing video we watched was from 1970. Like it had not, and I understand that like suturing principles haven't changed, but cameras have gotten better and we've gotten better at explaining things. And so we needed a more up-to-date video. We have a lot of really professional filmed in a licensed clinical skills uh, facility for you guys, like a hospital, to make it as easy for you guys as possible to understand those clinical skills. So join this, guys. It was wonderful to have you guys here today. Thank you for joining. My email down here, nursepractitioner@archerreview.com. Feel free to reach out to me with any questions, any issues, any feedback. I'm always happy to take feedback from you guys. I was happy to teach this, and we'll see you guys next time.